Let's see, we should be going live here. Hello, everybody. Good evening or good afternoon, depending on where you're joining us from. Thank you so much for being here with us tonight. We're really excited. We're going to be talking about what to expect in the future for cutaneous lymphoma. So we're going to be having sort of an open discussion and just talking about what's going on in the world of cutaneous lymphoma. And tonight we are so excited. Joining us is Dr. Oleg Akilov. Dr. Akilov, is an assistant professor of the Department of Dermatology at the University of Pittsburgh, and he's also the director of the Cutaneous Lymphoma Program and Extracorporeal for Photopheresis Unit. Hi, Dr. Akilov. Thank you so much for being here with us tonight.
Hi, how are you?
Awesome. Thank you. We're thrilled that you're joining us, and we're just going to kind of keep tonight's program informal, so more of a discussion. During the program, if you do have any questions or comments, feel free to just enter the question in at the bottom of your screen. There's a little icon that says Q&A, so just go ahead and type it in there. You can also type into the chat function and we can chat with you that way too. So Dr. Akilov, I don't know if you want to start us off and maybe give us an overview of just sort of what's going on right now in the world of cutaneous lymphoma.
Absolutely. Well, welcome everybody. So there's a lot of interesting stuff happening in research. Unfortunately, this year, as you know, was complicated by COVID pandemic. So some stuff that we were looking forward was put on hold. Mm-hmm. Still, we have a lot of interesting drugs in clinical trials, a lot of interesting components right now in development in a lab and being tested actively in human samples and animals. So we will have some interesting stuff, I believe, in 2-3 years when everybody recovered. I just want to share a couple of slides and show you why, research in lymphoma is so complex and what we are facing and what we learned from other cancers. So let's look at the screen. Let me see. So really busy slide over here. Let me just pull it a little bit like this. Can you see it well? So over here, you can see different compartments, right? And this is very busy slide again, but this shows you what's happening in the human body when immune system sees malignant cell. And malignant cell over here is these blue round circles. So there's a lot of different receptors on the surface of malignant cell. And those receptors presented as those tiny little blue with semicircles thing, right, on the surface of the cell. And we have several group of molecules, antibodies, that can recognize those receptors.
Dr. Akilov, can I interrupt you? Are you able to put it into the slideshow view?
Sure,
we just had someone ask just so it could be a little bigger. Thank you so much.
Can you see it better?
Yes, it's perfect. Thank you.
Okay. Let me see if I can grab the laser pointer. Can you see laser pointer?
Yep.
Excellent.
Thank you.
So there's a lot of stuff happens within malignant cells, right? There's different metabolisms, there's different interaction with mitochondria. This is mitochondria in the cell. And those receptors, it's part of immune system that malignant cells using to avoid recognition of immune cells, right? And hide from immune system and proliferate rapidly without being damaged. Over here, you can see there is a vascular changes. So blood vessels grows into the tumor because tumor, those cells are actively proliferating. They need a lot of supply, a lot of, it's an active metabolic cells. So they usually require blood vessels for their growth. And when malignant cells finally become recognized by different cells of immune system like macrophages, natural killer cells, T cells, then there's a lot of molecules, a lot of agents that can be used to modify cells of immune system to make them more active, more responsive to attack malignant cells. So for example, look at this one. This one that looks round with kind of like bean-shaped nucleus, this is called macrophage. Those cells usually come and eat malignant cells. So how to make macrophages more active? Because tumors are not stupid. They sitting, they hiding from immune recognition. And malignant cells usually interact with macrophages and telling them, do not eat me. I want to be hidden. I don't want to be bothered. And macrophages unfortunately listen to them. But there are some peptides like interleukin 12 that we can use, that we can push macrophages into recognizing malignant cells, and malignant cells can be eaten later on. The same story happens with other cells like natural killer cells, T cells. There's various receptors, right? This is how cells interact with each other. And there's various receptors on the surface, NK cells, that can get a secondary signal and get activated. And those receptors are CCR4, CD4, CD47. And those NK and NKT cells can be again pushed into work a little bit more efficient. So as you can see, there's a lot of different and complex interaction of malignant cells and cells of immune system. This is called tumor microenvironment, and this is one of the hottest subject right now in CTCL research. So a lot of researchers looking for particular cell type like T cells or NK cells or macrophages, and they trying to kind of tease it out, just because the whole story is way too complex, right? To kind of like try to attack from different angles. So this is what we're trying to do later in life. When we treat the patient, we choose several different agents, sometimes, not always, but sometimes we use several different agents that can work from different directions. And that's usually very, very beneficial than if you explore just one path and like keep pushing on it and it doesn't lead anywhere. But in research, it's much more encouraged if you choose just one particular path and dwell just in this particular direction, but you will know everything about it, how it works, why it works, what blocks this interaction, if we're, for example, talking about macrophages and malignant cells, what stimulates this interaction, what medication can stimulate interaction. But prior to that, you need to go back in the lab and see why those macrophages are not getting activated, right? If you ask, so researchers usually ask themselves tiny little questions, right? It's called hypothesis-driven research. When you have several facts, right? You know that there's macrophages, there's malignant cells. This is a fact. Then you know that macrophages become inactive when they sit in tumor microenvironment for a long time. It's also a known fact. So then you need to develop a hypothesis, right? How we can activate macrophages. And the hypothesis, for example, is just because this and this receptor interaction is affected in cutaneous T-cell lymphoma, we propose that if we're going to break this interaction, macrophages become active, right? And then you need to prove this hypothesis. Then researchers go into the lab, create a model, because we do not experiment on live patients. It's never happens. So it's usually model, right? If it's a simple model, cell and cell, researchers can get cells, human cells or animal cells. And by blocking these different agents, they can prove or disprove their hypothesis. This is how it works. Usually research is being supported by Cutaneous Lymphoma Foundation, by NIH, by private foundation, by pharmaceutical companies. If some of the agents that seems to work in particular way already available clinically or available for research through pharmaceutical companies. So, to conduct research, usually people need money, because you need to run the lab, you need to have technicians, postdocs, investigators to do the work. So I'm just trying to give the whole complexity of what's happened in research and how it looks like. So when a hypothesis is proven, right, this is when researchers come out, present their data on a big meetings, discuss it with other collaborators, with other experts in cutaneous lymphoma world. There's usually open, sometimes heated discussion if data is interesting or completely unknown, because it can truly revolutionize the field. If it has direct translational potential, like we were discussing, like on this picture, right? There's several components that's already available. For example, like interleukin-12 is available, CpG, oligodenucleotide available through some clinical trials. The next question is going to be, are we going to expect good enough results to bring those components into clinical practice? Of course, we cannot just grab it and say, like, listen, I did some stuff in a lab on 2 cells. Seems like it's going to work. Do you want to take it? It doesn't work like this. There's FDAs, there's NIH. So this kind of component, perspective component, needs to go into clinical trials. And there's usually several different sets of clinical trials. We need to prove that component is safe. Then we need to prove that component is efficacious, right? Otherwise, why we're even talking about it. And then we need to show that component is efficacious against standard therapy or something else that's already was available. That's truly beneficial to put a lot of effort into, offering this medication to everybody. So going back, since disease is very, very complex, there's a lot of different researchers, a lot of different groups that work on different parts of this busy picture. So for example, we were talking about macrophages. There's researchers from City of Hope particularly interested in this. We were working on NK cells and CD47 molecules, for example. There is a lot of research was done in Stanford with CpG, oligodenucleotide. There was a lot of research done with toll-like receptor. It's particular receptors right over here as is shown. That was done by University of Pennsylvania. One huge field that's not quite got yet in our disease, but it's a CAR T therapy, right? When people trying to modify genetically T cells, your own, like patient-owned T cells, teach them to recognize cancer, their own cancer. So it's already sounds very, very expensive, and it is. It's usually like $500,000 treatment. So they take T cells, teach them how to recognize malignant cells, and reintroduce them back. And those T cells attack malignant cells and supposed to clear tumor. So there's a lot of issue in CTCL with this approach, because CTCL, Sezary syndrome, mycosis fungoides, it's a malignancy of T cells, right? And we trying to teach T cells how to attack T cells, right? So there's a lot of discrepancy, and there's a lot of similarity and a lot of issue. It will be easier, and it is easier, if malignancy does not come from the same cells that you need to teach, right? If you have, let's say, melanoma, if you have B-cell lymphoma, when cells are different origin. When there's the same origin, there's an issue that's in some patients, and this is what we learn about cutaneous T-cell lymphoma, that's high genetic instability in those cells can repeat itself even in the peripheral T lymphocytes. So there is a risk. We didn't talk about vascular and stromal cell ablation that's shown over here, but this particular direction is very popular for solid tumors. When vascular component is very strong for breast cancer, ovarian cancer. In cutaneous T-cell lymphoma, it doesn't seem to be one of the main mechanisms, or at least not many people look into it. But truly, when we see lymphoma on biopsy, we don't see many blood vessels. So it's usually dense infiltrate of cells, and we don't see tons of blood vessels going through it. It's actually even a problem for therapy because, particularly for antibody-based therapy, because penetration of those big proteins is difficult to the center of the tumor. So it always feels like we treat on a periphery when we cannot get inside of it. I'm going to show a couple other slides if you guys are interested. So working on mycosis fungoides and Sezary syndrome, we are not alone, right? There's a huge field of researchers. There's huge number of researchers who work also in immunotherapy or novel method of treatments of other cancers. So we're constantly kind of like back checking ourselves. Where are we? Where they are? Are we on the same page? Are we doing the same stuff? Because when you work in a small field, there's always a risk there that you can get so specialized that you will be completely detached from reality, from what other people are doing. So for that reason, we have scientific meetings, we have meetings at National Institute of Health, we have publication, we have communication with each other. So we're all in touch with what's going on in the field, not just our field, but oncology, dermatology, immunology in general. So on this slide, you can see this is immunotherapy of melanoma. So melanoma, of course, was one of the first cancer for which immunotherapy was developed, and it's completely revolutionized the approach for those patients and improve survival of those patients. So everybody's super excited to see where melanoma research goes, because there's more patients, there's more money. Let's be open, there's more money in this field. So they have a big advantage to develop novel research. We're a little bit lucky because lymphoma frequently responds to similar therapies. So we don't need to invent the wheel. We can just look what's melanoma people doing and see if some of their findings can be beneficial for us too. So on the next slide, I want to show you where we are. So Michael Cutaneous, he was a lead investigator in this trial from Stanford. He just published, they just completed a trial with PD-1 agent. And look at this slide. So PD-1 agent in melanoma were in 2014, right? Now it's 2021, and this is where we are, okay, in lymphoma. It just came into lymphoma. So what's going to be next, right? So right now for melanoma, for example, people develop small molecules. It's an agent that target proteins within the cell. So we were talking a lot about those receptors on the surface, how to target receptors. So in melanoma world, they're already thinking about how to get inside, how to bring tiny little molecule and like a stick in a wheel, stick it somewhere in a path that leads to malignancy, leads to cancer proliferation. So if you put this tiny molecule inside like a stick in a wheel, well, it's not going to spin and the whole cell is going to start broken down. It's very cool approach, right? And you can see that there's several of them over here already. That's, you know, target different pathways, and you can stick, you know, that stick in one wheel in a second wheel, and you can get, you know, the stop mechanism better this way. So we don't have those molecules yet. Right now we have one clinical trial that's developing tyrosine kinase, that has tyrosine kinase inhibitors in lymphoma. So maybe in a couple years, we're gonna know if it's working for us as well, which is exciting. So it's coming, it's coming. We're a little bit behind, but it's coming to us too. Then smart people from melanoma world start using combinations, right? So not just small molecules, not just antibodies, but they're trying to put it together what if we're gonna attack malignant cells from several different paths, from outside, from inside, from outside, 2 different molecules from inside, 1 molecule in combination with another one. So a bunch of different combinations. This is our future too. We don't have yet any clinical trials that's exploring combinational therapies. We have one right now that has 2 monoclonal antibodies. We have actually a couple, but they just finish up protocols. So hopefully in the next year, we will start enrolling some patients into this. So we are approximately over here, right? 2021, in 2015 melanoma. And most recently, in melanoma world, they're trying to boost immune system. They're trying to boost immune system and attack malignant cells simultaneously. This is what it is over here. We're not quite there yet. We're still trying to figure out what's happened within microenvironment of those malignant cells. So we're going slowly, we're getting there. And let me show you, do we have any questions?
Let's see, we do. Someone said, for my MF, it feels like they are treating the cutaneous presentations, but not the genesis of the problem. Is that typical?
And yes and no. So if we're going a little bit back, right, and talking about etiology of cancer, not much known. So this is what we're talking about. So treatment in medicine in general, right, can be approached in 3 different ways. First of all, symptomatic treatment, right? So you have symptoms. For example, you're sneezing, you have runny nose, right? And we're treating it. We're giving you medication that constructs blood vessels and your nose doesn't run anymore, and that's it. This is symptomatic treatment. There is a pathogenetic treatment. So it treats not symptoms, but it treats the process that lead to those symptoms. For example, in this example with runny nose, there is a swelling of mucosa in the nose, there's enlarged blood vessels, so there's medication that can change it, and then, snot production is not gonna happen. So it's a pathogenetic treatment. And then there is etiological treatment. So for example, in case of runny nose, it's a viral infection, right? Mild viral infection. So instead of treating, running process, you can treat it with antiviral medication, okay? So this principle works exceptionally well in infectious diseases, right? And this is what the whole field is all about. You need to find the microbe and kill the microbe, and you're not gonna have all those symptoms that goes, all together with this. It does not work, unfortunately, like this in cancer very well. First of all, because we don't know what's caused cancer, right? We all would like to treat it etiologically. For example, Merkel cell carcinoma. It's a particular type of skin cancer that's caused by a virus, right? So in ideal world, you can develop a drug that targets that virus. And if you kill the virus, there's an expectation that cells that possess this virus is going to disappear too, right? In cutaneous T-cell lymphoma and mycosis fungoides, there is no virus. There's a lot of research, Pelorisa Gaskin by other groups was done. That's where we're looking into viral etiology of cancer. So at least there's no cancer, there's no virus that's caused cutaneous lymphoma, or it's not that straightforward. There's some, but they're not quite what causing lymphoma transformation. So if it's not virus, what else, right? So right now we think it's genomic instability. We think it's so much changes in the genome of that particular cells happens that it's like a cup of water that's keep filling every single year, more and more due to environment, due to genetic predisposition, right? Immune system missed it. Maybe parents carried some kind of abnormal mutation. But again, it's not the full cup. It's a little bit, right? Age, it doesn't clear abnormal genes not being cleared sufficiently. And let's say it's age of 63, 65, that cup of water, cup of genome become overloaded and start pouring over. And this is where proliferation, malignancy, cancer starts, right? So do we know which one exactly, right? So in this particular patient, that drop was the last drop, right? In another patient, it was totally different drop, right? Something else set it up. So should we go after that drop that set it up and treat that? It's probably not gonna work because the whole cup of water was already overflowing. So it's not about a drop. So even sometimes we feel like that was a factor that set it up. There is no reason to go after it. Speaking about, so etiology, we cannot address it, right? So there is a lot of instability in genome that we cannot stabilize at the current level of science, maybe 100 years from now, maybe 50 years from now. But right now we cannot. So can we do, if we cannot do etiology, right? I'm going backwards towards symptomatic treatment. Can we do it pathogenetically? Pathogenetically, we can, right? And this is what I was talking about. So there's a microenvironment, right? There's a malignant cells over here, but there's a lot of different mechanisms that can control it or clear it. So those mechanisms, mechanism of pathogenesis, mechanism of cancer development in a particular body, we can regulate. We can activate immune system. We can destroy tumor cells directly with cytotoxic agent. We can bring new cells, to clear and teach them how to do that. So pathogenetic mechanisms exist and we have them. And there's symptomatic treatment that a lot of people feel like they're not efficient. There is another issue though over here. Pathogenetic therapy does not clear because it doesn't direct towards the mechanism that's caused cancer, right? They don't clear cancer in 100%. They work for some people, they don't work for another people because mechanism can be slightly different. Our mechanism of manipulation are not very well established. So as you can see on the slide, it's still on a screen, right? We're a little bit behind. So we just start learning. And, melanomas trials, it's only 6 years, right, of this knowledge. Maybe a little bit longer because a lot of stuff was happening in the lab and didn't kind of get to fruition. So we were knowing those mechanisms for 10, 15 years. Okay, so we just start figuring. So our apparatus, if you wish, it's like us driving the tractor. We're not in Tesla yet. So we know how, we know what to pull, but we cannot kind of like do it very elegantly. We can do straight forward, we can do back, some of us can do side and, left and right. But it's not Tesla, it's nothing fancy, okay? So for that reason, those pathogenetic mechanisms, which those treatment modalities, we're trying to keep only for advanced diseases because they have way too many side effects, okay? We cannot just give it to everybody because again, imagine that you've been asked, park gently, between two cars where there's a barely place for one car and you've been given a tractor to do that elegantly. So you're gonna hit a lot of stuff, you're gonna create a lot of damage on the road. For that reason, we need a patient who already failed something, who disease progressed so much when collateral damage kind of like overweights what we can provide, right? So it's usually advanced cancer, it's usually tumor stage, mycosis, fungoides, metastatic disease, this stuff, unfortunately. And another very important point, that disease in early stage, mycosis fungoides in early stage, patient with that condition live as long as everybody else in their age group. Just think about it. If we're gonna treat, or we're not gonna treat stage 1A disease, 1 or 2 patches on the buttocks, it's not gonna make any difference. Okay, so even without treatment, lifespan is not affected. Patients still gonna live as long as somebody else outlined.
Is that stage, are you saying that's stage specific?
Stage specific, it's for stage 1A.
Gotcha.
Yes. For stage 1A, patient is gonna live as everybody else in their age group.
Okay.
We cannot, unfortunately, tell 63-year-olds it's gonna be another 100 years. Right. Because US statistics tell us different number, but at least we can say, like, if everything is gonna go well, that number is totally possible. This is huge, right? This is huge. Even without treatment, people can live as long as everybody else in their age group. So if patches are asymptomatic, if they're not itchy, if they're not discomforting for patients, right? Why do we need to start aggressive therapies that's going to hit kidney, liver, heart, other organs, right? If we can treat it symptomatically, what's bothering you? I don't like how it's look. We can get rid of it. What doesn't bother other patients? It's itching. We have anti-itch medication. So we can treat symptomatically. We're not going to cure lymphoma. We're not even promising it, right? But at least it's not gonna bother. It's not that deadly of a cancer, like melanoma, like breast cancer, like ovarian cancer. In stage 1A, it's manageable. Unfortunately, 25% of patients in this stage do progress. We don't know who, right? That's the reason why you see specialists in cutaneous lymphoma clinic on a regular basis, because if there is a disease progression, we change our approach. But for 75% of patients, that's the story. You know, it sometimes comes and goes, sometimes it disappears completely during summertime. Sometimes
someone said what to do to ensure that you don't get to stage 1B. Is there anything to even report how to keep the disease from progressing, or is it just sort of
so funny enough, yes, absolutely. So if you completely abandon your skin, right, if your skin is going to get dry, eczematous, if you completely don't care about your body, of course things can go down. But at the same time, nothing extraordinary. Healthy lifestyle, stressless life as much as you can. Funny to say it during, you know, this COVID pandemic, right? I think level of stress is over the roof right now for everybody. Good skincare, because dry skin attracts inflammation, and lymphocytes, malignant lymphocytes, may get additional stimuli from dry skin, from itchy skin. So it's very important to keep skin comfortable and happy. So the lesions, those patch MF lesions, not gonna spread out. But again, symptomatic treatment, you know?
Someone then said, is there any research indicating that those with mycosis fungoides might develop into another type of cancer, or might develop another type of cancer?
So mycosis fungoides is not going to transform into anything else, but just because we were start talking about genomic instability, right? My example is with a couple. So there is some theory that this genomic instability can be in different cell lines as well. And in fact, several groups actually, several groups did the study when we were looking for second cancer, right, in patients with mycosis fungoides. And all of us were able to find, usually Hodgkin lymphoma is number one, but even some solid tumors. But this is more a story of chicken or egg. it's a little bit difficult to establish. It's certainly not the presence of mycosis fungoides in the body, but some kind of different substitution, some kind of different genetic predisposition. That's kind of like goes into MF, into other cancer, into something else. So it's not one into another.
Right.
Something got broken on a basic level and now manifest in the skin and somewhere else. Okay.
Yeah. Let's see. Someone asked, are you familiar with the work being undertaken with NMT inhibitors specifically for B cell or T cell lymphoma?
Let me look. Let me look at the question.
It's in the chat.
NMT.
I just messaged it to you too.
No, I'm not familiar, not gonna lie.
Okay. Let's see. Someone else said, I have learned that drugs can be highly effective, manageable, and tolerable, but may not have a long duration of effect. In your perspective, what is the reason?
Well, there's a lot of reason, unfortunately. So first of all, there's particular way how the drug needs to be used. If we're talking about topicals, there's particular adherence to topical therapy needs to happen. For example, if we're talking about mecloretamine gel, it needs to be applied in very thin layer, right? If we're talking about topical steroids, they need to be really rubbed in. So sometimes it's not that obvious what and how and when. And treatment failure is sometimes caused by incorrect application of medications. Some people think if they're gonna slap, some kind of cream and ointment, put some clothes on, all those medication goes directly into the clothes. So this is number one. If we're talking about oral medications, there's a lot of finicky moments, unfortunately, with those medications too. Absorption rates certainly depends on what you eat, how you eat, and eating pattern. Some medication works better in the morning hours, some medication works in the evening hours. So this is important to remember too. So that's the reason why you have a doctor when you need to discuss all those minutiae.
Right.
Because, for example, very good example, doxycycline, very popular antibiotic. But if it's drinking with milk, it's being bound by calcium in the milk and goes directly in the toilet.
Wow.
So there's a lot of issue like this, unfortunately, with all those medications.
Yeah. So just very important to consult your doctor.
Yes, exactly. And sometimes that's the reason. I'm not even talking about, a lot of us start taking a lot of different medications and they interact with each other. You're taking drug for lymphoma, but you have couple medications that's changing, for example, for cholesterol level, for hypertension. They start interacting and everything goes not where it's supposed to go.
Yeah, that's a good point. Someone said, I have been at stage 1B for almost 10 years. Are longevity outcomes good for 1B?
For 1B, not as great as 1A, but still, yes, absolutely. It's still a good stage to be in. It requires a little bit more attention when we're talking about 1A and say like, listen, you can treat, you cannot. For 1B, usually you need to be on top of it. You need to be on top of it. You need to be sure that disease is under control. If you can bring your 1B into 1A, it's much better. So it's certainly not a situation when we can say like, live life. No, you need to put effort into control on lymphoma.
Let's see. Someone asked, do you see the mRNA technology that was used to develop COVID vaccines having a role in creating treatments for cutaneous lymphoma?
So yes, absolutely. We actually had one trial when it was mRNA-based technology. It's slightly different approach. So for COVID vaccine, for example, RNA-based vaccine were aimed to produce that spike protein, right? And then mRNA would disappear from the cells when enough spike proteins formed. That's it, they're gone. our approach, not our, but some groups, it was found that several microRNA were upregulated in in malignant cells. So when they start digging kind of like why there's extra level of this particular mRNA that's nowhere seen anywhere, they found that they regulate cytokine response of malignant cells. So it was an idea of suppressing them. So bringing mRNA that would bind another mRNA in a cell and provide suppressive effect. So it was a trial where we injected it. It was some ideas to put it in microneedles and deliver it locally because they're very unstable. It's really tricky you cannot swallow it, you cannot get it IV. They being completely destroyed momentarily by proteases in the blood, in the serum. Or like if you swallow it, juice in the stomach destroys them the same second. So it's really cool technology. And it's very popular, for example, in the lab when we have one cell and we have mRNA and we can, put it right where we need it. In real life, it's a little bit more tricky because even when you inject it in a tumor, it's kind of like goes, God knows where it goes. Yeah. So, but it needs to go right into malignant cell. So short answer, yes. Long answer, we're still working on precise delivery. And this is the biggest problem with that. But technology is cool.
It is. Let's see. What are your thoughts when MF moves to 2B and tumors have been treated with radiation when caught very early? And then he added longevity, follow-up treatment, etc.
So radiation is very popular treatment, very old treatment. We all love it and we all use it. It's certainly a lifesaver for single tumor, right? Single persistent plaque, even if it's not responding to therapy, but the infiltrate is decent enough already. And to be non-responsive to topicals. I like radiation. I think it's certainly good treatment, especially during COVID, when it's difficult to go from hospital to home, it's difficult to get chemo, how it's needed. So it's a good treatment. It's a good treatment. Longevity depends on stage. So if you're already in 2B, you need to be certain that no more tumors popping up anywhere else. Unfortunately, there is a risk that they will keep coming. It's a big question if there is a maintenance therapy needed for CTCL. I think there is. In big oncology, people don't do maintenance regimen for Hodgkin lymphoma, for something like this. But we do. We use bexarotene, we use other therapies, but it's center specific. I think bexarotene is a good drug to be for maintenance, but there are other medications as well.
Okay. Someone else regarding radiation said, if after radiation therapy for FMF stage 1A, the same patch appears again 3 months later, what options are left for treatment?
Well, there's oral medications, right? There's immunotherapy, there's interferon, there's a lot of different agents. Okay. There's a lot of stuff.
Yeah, a lot of things that can be done. Let's see. Someone asked, have you used nitrogen mustard to treat plaques? My doctor said it was out of favor for years, but now is used again. Do you have an opinion of nitrogen mustard over topical steroids like Clobetasol?
So nitrogen mustard certainly become more and more popular right now because of mecloretamine gel, because of pharmaceutical support of this option. It's a little bit tricky for thick lesions because you need more medication, and medication unfortunately causes a lot of irritation. Sometimes lesions can become erosive and even ulcerative. Not everybody for it. Like, let's say if you have a lesion that didn't cause any issues and now you put a nitrogen mustard in it, and the special lesion is thick, so you're gonna get a lot of area of dead malignant cells that's gonna break skin open. Will you be okay with that? If you're gonna be okay with that, go for it. But let's say, if it's antibiotics and it's some kind of area that's, not easy to treat, not easy to take care of it, it can get infected. It can ooze constantly, right? So you need change of clothes regularly. So it can create a lot of issue in your life. So I wouldn't choose it as number one personally. But I had a patient who had a big plaque on the face and it was bothering him, and we burn it this way. Right. We start using it frequently and it disappeared. It took a while. It took a while to heal too, but it didn't come back. Okay. So it's possible.
Yeah.
And steroids, clobetasol under occlusion works. Unfortunately, steroids have side effects like they cause skin atrophy. So you need to use it a little bit more carefully, especially with. I use it for some patients. I do it even under occlusion, yes, but it's can be tricky with the long term.
Okay, I just messaged you the next one, but they said, was TLR9 used to treat MF or Sezary as one single drug? Would a combination of drugs increase the toxicity? And then added, does the toxicity worth it given long-term of the disease and under the event it doesn't have a long duration and effect?
So toll-like receptor was used in one trial. It was single drug, just a direct injection into plaque and tumors. In another trial, I don't know if it's maybe even ongoing trial, they used toll-like receptor and radiation together with the idea to boost immune system, to create an inflammatory environment where malignant cells is going to be removed by immune system. Would combination increase toxicity? Not always. So it depends what you mean by toxicity. For example, for toll-like receptor agonist, inflammation is desirable. So what can be perceived by patient as a toxicity, skin is getting red, this is actually what we want to have, right? With intralesional injection, sometimes there is a flu-like symptoms, there is like systemic response, but again, it's a boost of immune system. So this kind of toxicity, we can take care of it, and this is what we want to have. It's a different issue when we talk about toxicity from chemo. So sometimes when we use two different chemotherapeutic agents, unfortunately, toxicity level doubles. And if one agent hits one pass and another, you get toxicity on both ways. But again, we don't do it for patients with early disease. If we're talking about systemic chemo with two agents, it's already metastatic disease. It's a disease with bulky lymphadenopathy. It's stage 4. So over here, we're talking about, life-death situations. So unfortunately, we have to do what we need to do.
Okay. Let's see. He said, I have stage 4 CTCL Sezary since November 2013. I've had multiple treatments over the years. Since 2018, I have taken Moga. My blood is good, but my skin is not. I had total skin radiation this past fall with great results. However, it was short-lived. Have you added any other drugs along with Moga to help with the skin conditions?
I like combining Moga with interferon. I had a good results, and in our center, I currently actually start everybody in Moga and interferon. But in your situation, I think clinical trial would be a good next option, because you already tried Moga, you already tried total body skin radiation. There is a Telemac trial that has different targets different receptors than CCR4. It's a KIR receptor. There is small molecules. There is tyrosine kinase inhibitors. There's different immunotherapy molecules like anti-CD47. And that molecule can be used also in combination with other agents, with Moga, for example. There's NCCN trial right now. So there's options. I think clinical trials would be the next one.
Right. Okay. You encourage people to join clinical trials at any stage?
No, usually not. I think for clinical trials, first of all, you need to have particular personality. You need to be willing to commit, right? You need to come to center. So sometimes even living far away kind of like excludes you already. For early disease, clinical trials sounds horrible, but it's more kind of like for fun. Because if it doesn't affect, life situation, and you want to contribute to science, again, for example, my center, I don't have trials that's experiments on people. So I only bring drugs that I truly believe in, and I think it would be beneficial. Or sometimes insurances doesn't cover anything, and it's an option for a person who cannot afford anything to get a drug for free in exchange to extra blood draw or some additional tests that's usually done on patient samples. Advanced disease is different. We just talked about a patient with Sezary syndrome when one medication didn't work as expected, radiation didn't work. So for those patients, I try to have a lot of trials for advanced disease, because sometimes we do go from one bucket to another and constantly trying something else without knowing what's going to stick, what's going to help to this particular person. So it's good to have options, because we have only 5 FDA approved drugs for advanced disease, only 5. It's not that much. So 5 plus combination of them, right? So there's some options. But after 2-3 years of resistant disease that's failed, all of them, right, we're running out of options. So for that reason, there's trials.
Okay. Do you recommend chemotherapy for MF? If not, what is the best therapy for someone who has been maintaining for over 17 years and recently has flared up after another recent biopsy?
Well, first of all, what's chemotherapy, right? So nitrogen mustard is chemo too. It's a localized form of chemotherapy. I try to avoid a negative label of chemotherapy, because again, it's a general term, doesn't mean anything. Again, for 1A, probably not, but nitrogen mustard is localized chemotherapy. But I think person thinks about systemic chemotherapy, and certainly systemic chemotherapy for early disease is not indicated.
Okay. Let's see, another 1B question for MF. I was diagnosed 2 years ago and my skin did not tolerate light therapy very well. Narrowband UVB treatment started at a low level with gradual increase, but the skin was burning. I don't have any itch and disease seems to be stable. For now, my doctor and I have agreed to just watch the disease. Do you have any thoughts on this approach?
I think it's a good approach. Yeah, watchful waiting is absolutely acceptable if disease is under decent control, if it's not progressing. Stable disease is a good disease.
Okay.
Especially, don't forget, sometimes there is a situation when patients being overtreated. It's a difficult burden on, on a patient, on support people who are around the patient, and even in the hospital. So sometimes it's good to take a break.
Okay.
Imagine COVID. It's good to get away and do something else, right? The same idea over here. Just going from one therapy into another and not having a break sometimes create a mental block. So I encourage my patients to sometimes just do nothing, come back, and we will see.
If it's well managed.
Exactly. Even, if disease is stable and doesn't require anything right now, having a couple months break. But sometimes even with advanced disease, funny enough, patient become overtreated and just mentally, cannot continue anymore.
Right, it can be so draining.
Of course, not couple months of break, but couple weeks of break. But this usually helps.
Okay. We have about 5 minutes left, so maybe time for about 2 more questions. Someone asked, what are the 5 drugs that you mentioned for advanced disease?
Bixarotene, romidepsin, brentuximab vedotin, Mogamulizumab. Well, Vorinostat is a 5th.
Okay. And for anybody watching, this is being recorded. So if it anytime you want to rewatch, you can always watch it on our website. It'll be on our live event videos within about a week of the program. So let's take our last question here. I have been treated for MF for 6 months. One treatment for my face is, I'm going to slaughter this name, Desonide 0.5%, which just leaves my face red, but Clobetasol on my body is improving it. Any comments?
So I think a person is thinking why we're not using Clobetasol on the face since it's helping on other locations. So the issue is that Clobetasol is too strong. Desonide is a weak steroid, class 1 steroid. So maybe, next step should be class 2 steroids. Something just a little bit stronger as a Desonide, but not as strong as Clobetasol.
Okay.
That could be a solution. Sometimes, skin is different in different location, different people.
Yeah.
It's important to find your medication.
Something that
among
works
steroids.
for you. Yeah. Great. Well, we're going to wrap up here. Thank you so much, Dr. Akilov. This was wonderful. We really appreciate your time and we're grateful for your expertise, and thank you for sharing with us this evening.
My pleasure. Stay healthy out there.
Yes, everybody as well. I did just launch a poll. If everybody wouldn't mind just taking a minute to just give us your feedback, we appreciate it. And just before we sign off, a heartfelt thank you to our corporate partners and our individual donors. Without you, we certainly couldn't put on these events. And upcoming programs, we have a later stage treatment options webinar on Friday, April 16th, as well as an open Q&A answers from the experts on Wednesday, April 21st. And like I said, the program will be available on our website within about a week. So thank you, everybody. Thank you, Dr. Akilov. We really appreciate it, and we hope to see you again soon.
Thank you so much.
Thank you, everybody. Have a great night. Bye.
Bye.